Since starting this podcast, I've had so many individuals reach out to me and ask, what is 22q deletion syndrome? And today I get to answer that question with the one and only Dr. Shruti Mitkus. She'll get right into the nit and grit of what this syndrome means. And I am so honored that she's on the show today. So let's dive right in and answer the question, what is 22q deletion syndrome? Here on the 22q podcast. Welcome to the 22q podcast. My name is Becky White, and today I am so honored to have genetic scientist Dr. Shruti Mitkus here with us. She works for Global Genes and is going to answer all of our questions around what is 22q. And to give our audience a little bit more background about Global Genes is a global nonprofit advocacy organization for individuals and families fighting rare and genetic diseases. The organization is associated with the Blue Denim Genes ribbon that is intended to raise awareness of patients affected by rare and genetic diseases. So, Shruti, thank you so much for being on, and please introduce yourself.
Thank you so much, Becky. I'm so grateful to be having this opportunity to talk to your audience. My name is Shruti Mitkus. I am the Director of Genetic Education and Navigation. And a little bit of background about myself. I am a geneticist by training, so I'm a human genetic scientist. Please don't hold that against me.
Not at all.
I've been a scientist for about, over 20 years, longer than I care to admit. Been in the rare disease space for about 15 of those years, really trying to first study the basics of genetic disease and what that means at the molecular level, but then, and in my current role, translating that into understandable knowledge for patients so they can advocate for themselves. And that was my professional side. On the personal side, I reside in Raleigh, North Carolina. Been here for about 8 years, and I live here with my husband and my almost 13-year-old twin boys.
Nice. Well, thank you for being on today, and thank you for sharing that. Have you always been interested in science and genetics? What drew you to this field?
That's a great question. The answer is yes. I knew from almost sixth grade that I wanted to do genetics, which sounds really geeky.
Not at
But
all.
I was just fascinated, I think, by how, the mom and the dad's chromosomes mix together and create this completely unique human being. And sometimes things go wrong and cause problems. And so that whole thing completely fascinated me. So I knew from a very early age that I wanted to be a geneticist. I actually thought I would continue doing basic research like I was doing for a long while. But things took a turn. I realized just looking at numbers and data and graph and analytics just wasn't enough for me. I wanted the patient side of things. I knew very well how to describe data, but I had no connection to a patient and what that meant in real life. So that's why I found myself transitioning to patient advocacy, where I get to combine my love of genetics as well as being able to help patients where it really matters.
Right. And have you, before we met, had you ever heard of 22q and had experience with possibly a patient or family with 22q?
I had absolutely heard of 22q deletion syndrome. We learnt about it in grad school, but unfortunately, like I mentioned, all my knowledge was bookish. I knew about the disease in terms of genetics, but I had not met a single patient that had 22q, and I had no appreciation for what an impact it has, not just on the person, but on the entire family. So this is a great opportunity for me to learn as well about the community and the patients and their biggest needs, not just about the genetic side of things.
Yes. It's so great that you had that passion for the families and the patients, and you can see it as you're speaking. It's just, you're very passionate about this topic, which is just delightful. It's just nice to see when people are really in the field that they were meant to be in. And I can't wait to dive into the topic of 22q with you. So let's talk about it. If you wouldn't mind, with all of your experience in this field, what is 22q?
Sure. So 22q is a genetic condition. It goes by many different names: 22q deletion syndrome, DiGeorge syndrome, which many people are familiar with, Velocardiofacial syndrome, and I've even heard it being called catch 22. So it has a large number of names, but they all point to the same syndrome, 22q deletion syndrome. And the reason it's called 22q is because it is caused by a deletion or a missing part of our DNA that happens to be on our 22nd chromosome. So just a little bit refresher on basic genetics. Humans usually have 23 pairs of chromosomes, so 46 chromosomes total. Each of those chromosome pairs have a P arm and a Q arm. P arm is the short arm, Q arm is the long arm. It's just the nomenclature that geneticists use. And so 22q is caused when a piece of DNA on the Q arm of chromosome 22 is missing from one of our pairs of 22 chromosomes. So, as you know, we each get one pair from our mother, one chromosome off that pair from our mother, and one from our father. And so 22q is caused by about a roughly 3 million base pair that's missing from one of our chromosomes. It is thought that there are about 45 or more genes that are in this missing region of DNA. And as you can imagine, if the genes are missing, their function is missing, and that can lead to a large number of symptoms that patients experience. The same exact region is not deleted in patient to patient. So there's a little bit of variability as to how much of that DNA is deleted between patients, and that leads to what we call a huge variability in phenotype. It just means one patient with 22q might not experience all the symptoms as another patient with 22q.
Hmm. Which is so important, especially if someone is listening to this for the first time and possibly just got diagnosed or their child just got diagnosed, to know that there is a huge wide range of symptoms and things that could or might be present in their child and the person that is listening to this. So always keeping that in mind is huge. But thank you for that beautifully description of 22q and what it is. And I know in the 22q community, having been on this podcast, I hear over and over again, parents sometimes, and most of the time, mothers that carried the child feeling like, what did I do wrong? I am carrying the child. What was it that I did wrong? I know I felt that same guilt myself at some point. And this leads me to my next question of, how does 22q occur and happen?
Sure. So I just want to start off by saying absolutely there is no blame for um, passing on my bad genes. That is absolutely not anything that one controls. I say to people, we pass on to our children our hair color and our eye color, and their personalities are a unique blend of the mother and the father. We're not consciously passing anything on to our children. So there's absolutely no blame to be had or any sense of shame to be had. I know that's easier to say, but to really take in. But from the science side, I wanted to say that we really don't know what causes this deletion. We have some idea and we're learning more and more every day, but we really don't know. What we do know is then about 9 out of 10 patients, this deletion happens at random. It happens sometime either when the sperm is being developed or the egg at the time of fertilization or soon after when the baby is just developing. Having said that, there is a 1 in 10 chance that this condition is familial or inherited from an affected parent. But as you can imagine, the vast majority of patients that have 22q do not have any family history and do not have parents that also have this syndrome. So there's absolutely no reason for thinking that we consciously pass something on to our children. In terms of the science, we're still trying to figure out why this occurs, and I can speak to that a little bit more. But it occurs usually in a time called homologous recombination, which is just a fancy word for a process that we all have when the sperm and the egg are fertilized. Certain pieces of our DNA get exchanged, and that's what makes us not carbon copies of our parents. That makes us unique because our DNA is sort of rearranging to give rise to a unique individual. And so we are now learning that there are certain regions of our DNA that are more susceptible for this process of recombination to get faulty. And I can talk a little bit more about why that is. And it just so happens that the 22q11.2 region, which is deleted in 22q syndrome patients, is considered one of the highest hotspots for deletions occurring due to the presence of these unique DNA repeats, which I won't bore you with, but we're now starting to realize this is actually a hotspot in our entire genome, and this process gets altered more often than we think. But
Wow.
exactly why that happens, we're still not quite sure.
Wow. And when did scientists start to figure out that this was a hotspot? Or is this new
Not
data?
This is fair. Well, so in science, it takes a long while for a scientist to find something and then publish it. But this data has been recently discovered, and by recently, I mean in the last 5 years, we're not knowing more and more about what are called these repeat regions in our DNA that cause this sort of recombination. And just to give an idea of why would the genome continue to have this region and what is the use of it, the use is in evolution. As our DNA gets jumbled around, there's a chance that we might have a variant, a mutation that comes up that gives us an advantage of some sort, and that aids in evolution. But the downside is it can also lead to problems in the DNA that can cause syndromes like 22q. So it's a fairly recent discovery, but I think it's ongoing, and we're trying to find out more and more about what the function of these repeats are in our DNA.
Right. And with 22q, how could 22q be detected?
Sure. So if a physician suspects 22q, the first thing they'll do is get a detailed health and family history. And family history, like I said, is important because 1 in 10 chance of this being an inherited disorder from the parents. So once a physician has gotten a full history, they are now at the liberty of ordering a bunch of tests for the patient. These can be routine blood tests, just look for immune problems that a lot of times 22q patients have. They load a test like echocardiography, which will look at the heart because heart and cardiac defects are another common symptom in 22q children. But they can also order genetic tests, which is what we use as a definitive diagnosis for 22q. So the first screening sort of test that they do at the genetic level is called FISH, fluorescent in situ hybridization studies, which is a long word, but we call it FISH. And it essentially looks to see if certain genes that we know are deleted in 22q, are they present or are they deleted? So it's sort of a quick screen for 22q using FISH. This means that if the FISH test comes back negative, it doesn't mean that the patient does not have 22q syndrome. It just means we need to do further testing. And with that, we do something called chromosomal microarray, which again looks in more detailed at the missing pieces of DNA. But the definitive diagnosis in terms of genetics is something called MLPA, which is used to detect changes in the chromosome at a much greater molecular level. And using that, we can then tell the patient, right, there is a deletion in the 22q region. This is where the deletion starts. This is where it ends. And that gives you a definitive diagnostic answer that you have 22q.
Right. And I love that you mentioned that the FISH test doesn't always find 22q deletion syndrome, and it can sometimes have a negative test result, because I've had parents share that they did a FISH test, it was negative, so they didn't think anything was wrong until after the birth and there was cardiac issues. So thank you for sharing that. And if anybody is interested in any of these genetic tests, how would they go about getting these tests done for their child or someone they know who might have 22q?
Sure, that's a great question. So the first thing I'll say is it's really important to talk to your physician. Talk to them candidly about your concerns for your child. It's really important for you to insist on a genetic test if you strongly feel that 22q might be something that your child has. You might get pushback from a physician, and if that is the case, I highly recommend you ask them to explain to you why they think that 22q is not involved. And like we talked about earlier, there's a huge clinical variability to 22q. So it's important for the physicians to tell you why they think 22q is not even something to test for. If you do manage to convince your physician to order testing, they will connect you to a genetic counselor who will then order the test for you. You certainly don't have to go to individual labs to order a test. If you aren't able to connect to a genetic counselor, you are able to find one on your own, and this is where Global Genes comes in as well. We can connect you to genetic counselors that are either in your region or also provide telehealth appointments where they can guide you. They can explain to you if they think a test would be useful in your case, or if it wouldn't be, they'll be upfront about that. They can also help with understanding how to pay for a test, because certainly these tests can be very expensive and a number of times they're not covered by insurance. And of course, they can help you understand the results of a test once testing has happened. So for any parent who's looking to get tested, I think it's really important to connect with a genetic counselor. And the other part of that I just want to say is empower yourself with education. Know as much as you can within reason of the disorder and the symptoms, and really advocate for your child, and don't take no for an answer, because as we all know, it takes a long while to get an accurate diagnosis. A lot of times you're told, no, it's not that, and that's it. You're just shut down. Don't take no for an answer. If you suspect 22q might be involved, get a genetic test, and if nothing else, you'll rule it out. Now you
Exactly.
know it's not 22q. And
Hmm.
also know you're not alone. There are a lot of people in the exact same situation trying to advocate for their children to get testing. You're not alone.
Absolutely.
You can connect to a community, 22q Family Foundation, or others, whatever condition is involved. And Global Genes can help with that as well, connecting you to people so you don't feel completely alone and don't know where to go.
Yeah, absolutely. I can't tell you the number of families that have shared that with just to trust that parental gut feeling. And like you said, be that advocate and learn about the diagnosis, prove to the doctors and medical professionals why you want this testing. And then if you keep hitting brick walls, keep going. There are resources like Global Genes and other resources out there to help you, because it is an expensive test and they're not going to simply allow everyone to take this genetic test if they don't feel there is reason for it. And I did want to ask you, how long does the microarray take once you do get the confirmation from your geneticist that you can have this test done? How long testing typically take to get the results?
Sure, that's a great question. So it depends where you get that testing. Nationwide, there are different options for you to get testing. Typically, it's a certified commercial lab that'll do the testing for you because it's ordered through your physician and through your genetic counselor. And typically, in those commercial grade labs, the turnaround time for a typical microarray is about 4 to 8 weeks, depending on the backlog that they have. Most labs have gotten quicker and quicker. I would say they quote a turnaround time of about 4 weeks, from the time the test gets into the lab to the time you have a report in your physician's hands. The little caveat to that is if you decide to go to a research lab, which there are research labs that also do this sort of testing, their turnaround times are slightly longer because, again, it's a research lab. They're not doing this on a high throughput scale with a lot of patients. So anywhere between 4 to 8 weeks is typically what we quote for a microarray test, as well as
Mhm.
additional testing that
Mhm.
might be required. Truly, the test itself isn't. It's not as if the test is sitting on a machine or under a microscope for eight weeks, right? It's really a testament to how many people are accessing testing, which is great. But then it creates these long queues as well in a lab. So when I used to work in a lab, we had, over 1,000 active samples at a time, which we were sort of churning out. But that's just something to keep in mind, that once it's in the queue, you might get a test quicker, but the backlog is really more because of the volume of samples. And sometimes, in labs, you might run out of a chemical reagent, so you have to wait to get that order in, and those sort of secondary things. But it
Yeah.
typically does take that long.
Yeah. It's a great insight because you don't think of those things. You think, oh, I did this blood test. Why is it taking so long to get it back? But yeah, I've heard stories of 2 to 3 months until people hear back. So thank you for that insight. And I was just wanted to ask you also, over the past 20 years, what have been some of the significant scientific discoveries around 22q?
Sure. So there have been quite a few. So we've known about 22q. It was really first described in 1965 by Dr. Angela DiGeorge. So we've sort of known about this for a long while, but really it was named, and the discoveries were ramped up in the 80s. And since then, we've learned a lot about 22q. So like I was mentioning, the region that's generally deleted in this 22q region consists of about 45 or more genes. 45 of those are coding genes, and a bunch of them are what we call non-coding genes. But that just gives you an appreciation for how many genes in that region can possibly be deleted. And each of those genes are being studied to understand what are their functions, why do we see the symptoms that we see, and how do they relate back to the gene that is deleted. So ongoing studies have found that number of genes deleted. Of those, we know, having looked at a bunch of samples, we know the most common gene that is deleted in patients is called the TBX1 gene. And more studies are finding out that it is important in cardiac function, in parathyroid and thymus function, which affects the immune system. It's also important in the development of facial structures, which we know cleft lip and palate might be observed. So there's a correlation between the function of the gene and how its deletion can lead to symptoms. So TBX1 is not just the only gene that we know of. There's many other genes. We know a lot about the circle gene, the CRKL gene, which we know now is involved in cardiac development, which is also something that we see in patients. Additional genes like DGCR8 are involved in regulating other genes. So the gene itself that's deleted might have a functional impact because it affects cardiac development or facial development. But there are other genes that regulate the function of other genes. They're acting
Wow.
like switches that turn on and off genes. And we're learning a bunch of genes in that deleted region don't themselves make a protein that creates a function, but are actually regulating the timing and the amounts of the other genes that are under them. So we're learning a lot about that. Like I mentioned before, we've learned about the low copy number repeats that are present in this region, which makes it a really high hotspot for deletions and why we see microdeletions in this area. I failed to mention that 22q is one of the most common microdeletion syndromes that we have. And now we're trying to understand how these low copy number repeats that are present in this region, how they lead to this homologous recombination problem that happens. The other thing we're learning, which I think is interesting to point out, we touched upon the clinical variability of how one patient with 22q doesn't look exactly the same as another patient. And with what we found is when they did identical twin studies, so identical twins, they share the exact same DNA. It's the fertilized egg splits for some reason that we're still figuring out. And so each fetus, each child is genetically identical at the DNA level. However, when they did studies on identical twins that had 22q deletion syndrome, their phenotype, their symptoms were not identical. They had variability even in their symptoms, even though their DNA was exactly the same, and one would think the deleted region is exactly the same. So we're now learning it's not just all about genetics, it's something also called epigenetics, which are factors that influence how genes function when they get turned on and off. And that's why these twins have a not totally, but quite different presentation. Things like the position in the uterus at the time of development, access to nutrients in a slightly different manner, complications during pregnancy that may affect one twin and not the other, Things that don't affect the DNA directly but have an impact are all epigenetic factors, and we're learning more and more about non-genetic events that could also contribute to this variability in phenotype.
Wow, that is incredible. And I'm so thankful that there's research going on around 22q and finding these extremely interesting findings. And I'm just really excited for the next 20 years and seeing where this goes and what we find out. So thank you for that insight. And what sort of attributes, you already mentioned some, but what sort of attributes are connected with 22q?
Sure. So, despite the clinical variability, there are some common attributes that we think of when we think of 22q, which might give a physician pause and consider 22q. So, some of these starts off with developmental delay, so growth delay, developmental delay that when a child is not hitting those milestones. Speech problems are seen, and it's sort of related to the other problem of facial development that is not completely correct. And so cleft lip and palate are commonly seen. And this also leads to feeding difficulties in babies because of the structures not being formed correctly. Heart problems are quite common. Congenital heart defect be seen at birth. Because of the facial structural problems, ear problems can also be seen. High amounts of middle ear infections or hearing loss can be seen. These children also seem to have a higher risk for infections, so immune problems, which can be detected through blood tests. Kidney problems have been seen in many of these children, so typically either a kidney is missing or it's misshapen. And then, like we talked about, communication and social problems, there is a higher risk for certain mental conditions, anxiety, depression. And in fact, there is now a great amount of research in the mental health side of science that are utilizing patients with 22q so we can understand the genes that are deleted or whatever is going on in that deleted region, how they may impact the development and functioning of the human brain.
Mm-hmm.
So those are the most common defects and symptoms that we see in a lot of patients, but again, with a wide variety from mild to profound.
Yeah. And for any medical professionals that are listening, what would be some red flags right off the bat while the baby is still in utero, or maybe the first month of life, that if any of these pairings or combination of things are happening, when should they sign up to get a genetic test?
Right. So I think so physicians have a whole system of what they call a differential diagnosis. So when they see a bunch of symptoms, there are things that they automatically consider. 22q might not be up on that list, but I think for physicians listening, if you see a cluster of global developmental delay combined with cleft or lip palate, as well as heart arrhythmias or heart defect, that should certainly send a red flag to consider 22q in the differential, which also means genetic testing to be sent off as soon as you can. Because as you can imagine, while there's no current cure for 22q, early diagnosis is our biggest ally because the quicker you find it, the quicker you can get these children to the help they need and to the various specialists that are involved in their care. So to answer your question, earlier the better. If you see any of these sort of 3 red flags, and it certainly can be more or less, but that's why things like this podcast are so important, because if we get the conversation started, particularly in physicians' minds, that if you see these cluster of symptoms, it may be 22q and you need to order a genetic test as soon as you can so we can get these children taken care of.
Yeah, thank you. I wanted to ask that question just because there are thousands of different genetic conditions that can be patient to patient, and we're not expecting all physicians to know warning signs just for 22q, but just to have that nicely packaged the way you did, just to explain if you see any of these red flags, get the genetic testing done just to diagnose the child and confirm or not confirm whether they have it. Thank you for that.
Oh, absolutely. I think I just wanted to point out, in med school, when physicians are being trained, they learn about a lot of diseases, right? They're inundated with information. And unfortunately, rare disease is not given a lot of time, and particularly chromosomal conditions. And so, if nothing else, if they can just keep at the back of their mind to even consider 22q in their differential in a newborn that is symptomatic for some of these conditions, I think we'd have done a great service just to raise that awareness among
Yes.
physicians.
Absolutely. Because as we all know, we know a lot about Down syndrome, which is wonderful. I think the more syndromes we can get out there, the better, just to help the community, the parents, and the physicians know more. And I did want to ask you, having brought up Down syndrome, how is 22q different from Down syndrome?
Right. So 22q, as the name suggests, is a deletion syndrome, 22q deletion syndrome. And it is caused, like I explained, because of a deletion of a certain amount of DNA on our 22nd chromosome. Trisomy 21, or Down syndrome, as the name suggests, is not caused by a deletion of a certain amount of DNA on chromosome 21. It's actually caused when a person has an entirely extra copy of their 21st chromosome. So instead of having one chromosome 21 from the mom and one chromosome 21 from dad, these patients with Down syndrome have 3 copies of the chromosome number 21. And so we also call it trisomy 21, which just means 3 copies. So the way 22q is different is there's no extra copy of DNA. It's just a critical region of the DNA is missing.
Mm-hmm.
And this sort of highlights in genetics, I guess, like in a lot of things in life, too much or too little is not a good thing. If you have too little of the genes in the deleted region of 22q, you experience the syndrome. And if you have a whole extra copy of chromosome 21, as in Down syndrome, you also have problems. So it's a question of having just the right amount of DNA.
Mm-hmm.
Also, like I mentioned, 22q is one of the most prevalent microdeletions. It's about 1 in 4,000 live births is its prevalence. Down syndrome, on the other hand, is the most common trisomy that we see. It's about 1 in 800 to about 1,000 live births. So a little bit more common, but 22q is most certainly one of the most common microdeletions.
Right. Thank you. I did see somewhere that they are slowly starting to change that 4,000 to 2,000. Have you seen anything in your findings?
I have not, but again, I've only looked at scientific literature, which it takes time for it to trickle down. So
Oh,
I
yes,
I, I
it
wouldn't be
does.
surprised. Yeah, I certainly would not be surprised if the prevalence is higher, particularly with more accurate testing, earlier
Right.
testing, because I imagine there might be a number of kids out there that just haven't gotten the diagnosis just yet, either due to lack of access or it wasn't even ordered for them. So I wouldn't be surprised at all if that prevalence is even higher than we currently think.
Right. And that tends to, I'm sure you've seen that happen with other rare diseases as well.
Absolutely. It happens all the time as our diagnosis gets better, as physicians' education gets better. And certainly patient organizations are disseminating this knowledge. And so patient awareness gets better. That leads to greater diagnosis, and that directly impacts prevalence. The other caveat is there's a difference between global prevalence and just the United States. So I'm sure it's actually even more underdiagnosed in certain other parts of the world where people just don't have access to genetic testing. So I think as more data comes around from across the globe, I think we're going to find prevalence to be really going up, as we see in other rare diseases.
Right. I've met a few families that they had a child with diagnosed with 22q, and when they went to go get the genetic testing done for themselves, they found out they had 22q, lived their entire life not knowing it. So I'm sure that's very common with other rare diseases, that you may be walking around with a genetic disorder and you don't even know.
Absolutely. That's absolutely
Yeah.
true. And that's why I think, like I mentioned, I said, the literature says 1 in 10 cases are familial and untransmitted. But again, I'm sure that number is going to go up once more parents are being tested. And really, that's also, I just want to tie it back in. That's also where genetic counselors come in, because they can really review your history, your husband's history, going back a few generations, and unearth some things that might raise a few red flags, even though you don't think you have anything, and really be able to then give you a accurate what they call recurrence risks. So if you
Hmm.
decide to have another child, what are the chances of you having another child with 22q? So that's where that counseling from a genetic counselor who knows what to look out for is really important. But I'm sure that 1 in 10 number of 22q being familial is also going to be climbing up as more and more people get tested.
Yeah, I'm curious to see in the next 20 years if that number does continue to go down, just as people become more aware of what 22q is. As we continue to get more research, I'm just excited to see what happens and just to get more answers for families, more answers for researchers and scientists to learn more about 22q and see if there's a way to diagnose earlier and more accurately in a quick manner. But what other chromosomal conditions are you aware of?
Sure. So, like we had spoken about earlier, there are a large number of chromosomal conditions that we know of, and ones that we're finding more and more of daily, really. So, for the chromosomal conditions, we already talked a little bit about Down syndrome, which is trisomy 21, where there's an extra copy of chromosome number 21 in these patients. There's also trisomy 18, which is having 3 copies of chromosome 18, and that's called Edwards syndrome. There's trisomy 13, which is, as the name suggests, 3 copies of chromosome 13, and that's called Patau syndrome. There's also chromosomal conditions affecting the sex chromosomes, which are the X and the Y. So we have something called Klinefelter syndrome, which is XXY. So as you know, females have the XX chromosome, males have an XY. In patients with Klinefelters, they have an extra copy of X, so they're XXY, and that leads to some symptoms. And then the other side of that is called Turner syndrome, which are patients that have, instead of an XX or an XY, that second chromosome is completely missing. So they are what's called XO or X0. They only have 1 copy of the X. I just wanted to say, typically, losing an entire chromosome that is not a sex chromosome is not compatible with life. So we don't see live births of children that are missing an entire chromosome 1 or even an entire chromosome 22. It's just not sustainable with life. So what we typically see are what's called trisomies, which is this extra amount, which can still be compatible with life but lead to these syndromes.
Mm-hmm.
So those are the global chromosomal syndromes. There are then the microdeletion syndromes, like we talked about, 22q being one of them, but there are a lot more. Prader-Willi syndrome is one, and Angelman, which we know is again caused by deletions of specific areas of the chromosome. And there are a lot more, Williams syndrome, Wolff-Hirschhorn syndrome. So that just gives you a sense that we know about chromosomal conditions when either an entire chromosome is missing or additional chromosome is added, but also where little pieces of chromosomes are either missing or have also been added on as extra. There are
Mm-hmm.
a lot more, which I won't get into, but yeah.
Yeah. Thousands, right? Thousands.
Absolutely. And a lot of times the clinical presentation is very similar. So for example, in Edwards syndrome, trisomy 18, you do see cleft lip and palate. And so you can see there's a phenotypic overlap. And that's again why it's very important for physicians, if they see these sort of red flags, they order chromosomal testings because it'll rule out a particular condition, but you might end up also finding a new condition that you
Right.
didn't think of.
And we talked a little bit about Down syndrome before, but with deletions, including 22q, what other deletions are most common that physicians see?
Right. That's a great question. So we don't have data, at least that I'm not aware of, that sort of ranks the various types of microdeletions, but we see them all over the gamut of the genome. And most of them are not in hotspots like in 22q. They're sort of randomly dispersed around the genome. So I can't answer right away what the second most common microdeletion would be, but I just wanted to point out, there are certainly a lot more. And what's interesting is a lot of them are also what they call private deletions, which just means that they're unique to that particular family and haven't been seen in other families. There might
Wow.
be, yes, there might be some clinical overlap between conditions, but there are variants, mutations, deletions, insertions, all of those that are what we call private mutations and just haven't been seen. And so, really, the only way to raise awareness about those is to get that information published in a scientific journal, a scientific study, so that it's now in public domain. And when the next family comes along with these unique set of features, we can think about, oh, this particular microdeletion has been reported before. But to circle back to answer your question, there are many, many microdeletion syndromes. Which one is probably the second most common? I'm sure there's one out there that I'm not aware of, but just so your audience knows, there are a lot of
Lot.
them.
I kind
Yeah.
of threw that question at you because
No,
I didn't know even if there was and I wasn't looking for first or second or third. I just didn't know because you always hear about Down syndrome and people are starting to now hear about 22q deletion. I didn't know if there was another deletion that was very prevalent that was coming to
I'm
the forefront.
sure there is, Becky.
Yeah.
I'm sure there is.
Yes.
Um,
And if anybody knows, please write it in the comments of our podcast to let us know what that is so we can just get the word out. But thank you. And I wanted to just also mention global genes and see how global genes could help the 22q community or anyone listening. We will have another podcast with Mary from Global Genes. She is the rare concierge patient service manager, and she does a beautiful job of explaining all the services and programs that Global Genes does provide for families. And I simply just wanted to say, from a scientific side, just from you speaking today, it is so important that we are able to share as parents, caregivers, and then also individuals living with 22q to share what it is like living with this deletion for scientists and doctors to learn more and to simply just share what we find with the entire community globally. So I didn't know if you wanted to share what Global Genes could do or anything you would like to share about Global Genes and how it could help the 22q community.
sure. So, as I sort of alluded to earlier, suddenly getting a diagnosis, be it 22q or any other rare disease diagnosis, can be a very shocking, alienating experience. And when you get that diagnosis at first, what do you do? Where do you turn? What do we do with this information? And that's where Global Genes comes in. It can really help you, regardless of where you are in that rare disease journey, even being undiagnosed for years and years, to all the way, maybe perhaps being ready to fund research testing and drug development. So, anywhere along that gamut, Global Genes is there to support patients, caregivers, family members, advocates. We can help with things like, where do I get financial assistance? Do you have disability information? We can help with things like what I talked about. If you want to know about the genetics of it, or you have a particular deletion that's identified, help me understand what this means. We can connect you to a genetic counselor. If you are not able to get a referral through your physician, we can guide you as to databases that can provide you with connecting with a genetic counselor. We can guide you in areas where you can get free testing through sponsored programs. Global Genes ourselves doesn't offer genetic testing, but we can connect you to companies that may have these sponsored genetic testing programs where you can get testing. We offer mental health support. So an often overlooked aspect of the rare disease journey is just the whole impact it has, not just on the patient, but on the entire family. Caregiver support. We have resources for respite services for caregivers that are taking care of their children and their loved ones nonstop. So that just gives you a bit of a flavor of all the things that Global Genes can do. Not to mention, on our website, we have tons of resources and information just to educate you on the various aspects of rare disease that are not specific to 22q, but they span the gamut of common questions and problems and resources that anyone on the rare disease journey might be able to avail of.
Thank you. And I'm so thankful that Global Genes is available for all families trying to navigate these rare diseases because it's needed and so important for them to find this community and for the medical professionals, the scientists to also connect with these families and individuals living with these diseases because that's how we're going to learn and that's how we're going to connect and be able to help one another even more. So wonderful, wonderful organization. And I didn't know if there's anything else you'd like to add before we close today.
Sure. I just wanted to leave you all with the sense that there is scientific development in 22q. It's not been forgotten because it was discovered ages ago and now no one's working on it. That is not the case at all. Just last month, a Virginia Tech professor, Dr. Lamantia, was awarded an NIH grant to study a potential therapy for DiGeorge 22q syndrome. Last year, George Washington University School of Medicine received another grant from NIH that they used to develop a mouse model for 22q. And a mouse model is essentially where we take an animal, in this case a mouse, and delete that particular region of the DNA that's seen in 22q, and then we study its effects and potential therapies. And they're looking to use this mouse model to understand feeding and swallowing problems that are seen and how we can impact those. And if we intervene early, can that help in also preventing the development of cleft lip and palate? Clinical trials are still recruiting for 22q patients. Last I checked on clinicaltrials.gov, there were 8 trials worldwide that are recruiting actively for patients, either for an interventional study where a drug is administered or natural history studies, which are just studies where we collect data from patients so that we can share it with researchers and really understand what the symptoms are. And then patient advocates like yourself and in these communities, they're the ones leading the charge to get things for their children, get a treatment, get better support. So I just want to leave you with the sense that you haven't been forgotten. Science is still going forward with the ultimate aim of, if not preventing, then really treating these children early on. And I'm really hopeful, perhaps in the next decade, there's going to be something that's going to be really helpful for these families. So I just wanted to leave you with a bit of sense of hope there.
Yeah, no, we need hope. Well, do right. And I think it's a great point that there are people, researchers, scientists looking into this and it hasn't been forgotten. Thank you for sharing that. And thank you so much for your beautiful explanation of what 22q is and really getting into the science side of this deletion for our audience, just to understand what is 22q. So thank you so much for your time today.
Thank you so much, Becky. Like I said, I am so grateful indeed to be able to have this opportunity to help demystify the whole 22q syndrome and what it causes. So I'm the one who's truly grateful. And if anyone wants to has additional questions or wants to reach out, please feel free to reach out to Global Genes. I'm more than happy to help address any questions that you might have.
Thank you so much. Have a great day. Shruti, thank you so much for being on the podcast today and just answering my questions around 22q and raising awareness for families, friends, and neighbors. Thank you again. And if you'd like to contact me or the 22q podcast, you can reach me at 22qpodcast@gmail.com with any questions, concerns, or if you are interested in being on the podcast, feel free to reach out. And remember, 22q family, that you are not alone.